Morning, everyone. I think if you all saw Medical Oncology down to present today, you were a bit worried that we were going to present stuff that gets us really excited with lots of nibs and mabs and Kaplan-Meier curves. And we've decided that that's not what we're going to do today. So Dr. Molepo, who is a consultant in the Department of Medical Oncology here at Charlotte, is actually going to talk to you about your patients. The patient you see in diabetic clinic, the patient you see in renal clinic, the patient you see in cardiac clinic, the patient you see in room, where you can potentially identify who needs to be screened for a malignancy and who potentially can be picked up at an early stage if there is an underlying malignancy, and maybe actually avoid an interaction with your friendly medical oncologist. So I'm going to hand over to Dr. Molepo to give you a talk that involves your patients, not necessarily ours. Thanks.
Thank you very much, Prof, for the kind introduction.
You're good. I just want to make sure you can click.
And thank you to the Department of Internal Medicine for giving me this opportunity to talk to you. I'm Sam Molepo. I'm from the from the Division of Medical Oncology. If I could move the slides, I didn't do a case, and that was just on purpose. What I would have wanted is just like a short interaction with maybe the registrars and the medical students, the medical officers or community service officers. So this is a young lady that I saw in clinic. She's 33 years old. She's got an extensive family history of cancers, including colonic, breast. But in particular, she also has a child who has this choroid plexus tumor. So, of course, at the first consultation, she was quite worried. She said, "Doc, something is going on. Is it possible that I've got some sort of predisposition?" So I did send her for genetics counseling and testing, and they did BRCA testing, which was actually negative. But then we found this result. If you look in the bold red result in the middle, any of the registrars, perhaps, who knows what the eponymous name of the syndrome is? Registrars, MOs, anybody? No? No. All right. So this is Lee-Fraumeni. It's a familial disorder where it's a tumor suppressor gene that they lose activity of, which is important for surveillance as well as genetic repair of your chromosomal abnormalities. And so these patients have a predisposition to many types of tumors, but in particular sarcomas and breasts, and they may have hematological malignancies as well. And then just this case, which is unlinked to the first case. Again, if anybody wants to comment just on this X-ray, nothing else.
Something's missing.
Absolutely, Prof. So on the one hand, this case seems not to have another breast. The breast on the right side is missing.
Big round.
Absolutely. There's this round thing that got me a little bit excited, and we think it's a cavity, lung abscess. Absolutely. So I tried to call the patient because I was petrified. She had been complaining of a cough. She's actually a lady who had just had a mastectomy a few weeks prior, and then I was giving her adjuvant chemo. We're at cycle 4 at this point. And I was petrified because I thought, she's got a lung abscess. You x-ray them and then they leave the clinic, and then you'll call them if there's something wrong with the x-ray. But of course, our new stickers, I cannot read. The 6s and the 8s look the same. The 3s and the 8s look the same. So I need to ask this. So I had trouble trying to call her. But in my panic, I then looked at the lateral. So the abscess is actually outside of the lung fields. So this is actually a ruptured breast implant. Thankfully, she was asymptomatic for it. She's got an idea that the surgeons will remove it, but we'll see if she's fit enough. She is 83, so we may just leave it. She's asymptomatic for it. Sure. All right, so that's all I wanted to do for the cases. So just to get into the business of screening as well as primary prevention. So screening is effectively where we want to detect an asymptomatic disease or risk factors thereof in an individual who has no complaints. And so there's a few examples there. For example, mammography, standard mammography. pap smear. When we went to conferences in Cape Town in 2022, they would swab all of us for COVID. That would have been a type of screening as well. And then if you do a BP measurement in a patient with no complaints, that would technically also count as screening. And then primary prevention. So primary prevention is when we remove all risk factors in order to prevent a disease from occurring, in particular immunizations. If you go to a malaria area and you take prophylaxis, that would count. And as we'll see just a bit now, prophylactic surgery for patients who, for example, have genetic cancer syndromes. And then secondary prevention, we won't discuss today, but that's effectively what we do in most hospital settings where patients have complaints and you do the testing as well as the treatment to prevent that disease from complicating. And then tertiary prevention, again, is what we do in this institution where the patient already has the disease or even its complications, but we want to prevent that patient from deteriorating further. And I've put there as an example when we give a beta blocker to a patient who's had a myocardial infarction. So who to screen? So the biggest controversy with screening is, does it actually affect your outcomes? So just because you go to the mall, for example, and you screen absolutely every woman who walks past you for breast cancer, will you actually affect those patients' outcomes? And the answer is no, you won't. So it would not be cost effective for you to screen absolutely everybody. So because on the one hand, you've got tumors that are indolent by their nature. So those tumors may be in the patient their whole lifetime and never actually cause a problem for them, right? And you'll see now when you get to prostate, that's probably more of the case. Some older ladies may have, for example, what you call luminal A-like breast cancer, and this patient may, for example, have the lump at the age of 92. She may be asymptomatic for that lump, and let's imagine her life expectancy is about 2-3 years from the age of 92. You detecting the lump may not change the fact that she will still live to be 94. So you're not adding anything to her life expectancy by detecting the lump, therefore putting her through surgery, radiation, chemotherapy, where you may actually cause harm in such a patient. So generally speaking, you want to identify patients who are at a higher risk of such a tumor, at a higher risk of complications from such a tumor, therefore pin those patients down for screening. There's issues of what tools to use for screening. So each tumor, as we'll see now, has different tools that we use. And what you'd want to ask is, have we investigated which tumor is the best in terms of sensitivity, specificity? Have we looked at how labor intense some of the techniques may be? So for example, if you look at mammography, someone has to sit down and look at those mammograms, which may be labor intensive. Maybe I'd rather have a radiologist reporting on MRIs of brain tumors as opposed to sitting and reporting on mammography pictures. And then the other problem is positive as well as negative predictive values of these tests. What that means is if you do a test and, for example, mammography, and a lot of the lesions will be overcalled. Maybe these patients have cysts, maybe they've got fibromas, but they are more likely to be called a tumor. Therefore, your patients go through investigations they don't need. They have a lot of anxiety. They may not sleep at night because they now think they've got cancer where they actually have a benign disease. But on the opposite end are screening tests that are more likely to come back negative, even in the setting of a tumor, because now you've got patients who are falsely reassured, who may then have this tumor present symptomatically 2 years or so down the line, and then perhaps come in and stew, for example. The other issue is action readiness. So it wouldn't be very meaningful to screen a patient who says, look, I don't want surgery, I don't want radiation, I don't want chemo. Then, maybe we shouldn't put that patient through a screening program. And then the other issue is our institution ready? So if I detect a lesion on mammogram, when will this patient have, for example, the biopsy done, right? Once the biopsy is done and surgeons want to operate, when will that be? Will this patient have to wait 9 months for the operation? Because now, again, you've introduced anxiety into the patient, you've introduced more labor-intensive stuff to be done by an institution that's already got emergencies, that's got other planned procedures and long waiting lists. And then the other issue is how frequently. So now you saw the patient in MOPD, you did a mammogram, it's negative. So when else must you repeat the mammogram? And do you do that for the patient's whole lifetime, or can I do 2 mammograms for your lifetime? So we'll cover a little bit of that just now. And then, of course, cost implications. So again, the screening tool also has to look at that. So is it cheaper to do one screening tool versus another? And then again, as we said, if you're screening the general public, that will also increase your costs. Whereas if you screen a subgroup that's considered high risk, your costs may come down. And then, of course, finally is, will this patient benefit, which I've touched on a little bit, is will their quality of life change because you detected this tumor early? Will their overall survival be impacted because you detected the tumor early? Or does the patient still die? Maybe some of the tumors are inherently deadly. And so you've done all of the tests, you've picked it up early, you've done the surgery, the chemo, the radiation. However, the patient still relapses, still metastasizes, and then still demises. All right, so the first one is our bread and butter, which is breast cancer. If you look, this is the National Cancer Registry in South Africa. Our latest data, certainly as I checked, was from 2020. But you can see that in this pie chart, all right, on the pink component in the pie chart, that's breast cancer. And it's by far the commonest cause of cancer-related morbidity and mortality, and that's worldwide, not just in South Africa. And then it's followed closely by cervix, which we'll touch on a little bit. And then if you look, you also see colorectal, and then there's uterus, which is probably mostly endometrial, but there are other uterine tumors. And then there's a group there called CUP, which is carcinoma of unknown primary, which is another entity. So as we just said now, high-risk groups generally benefit more than screening general populations. And I think I've covered a few of these. So, and then just the topic of overdiagnosis. So overdiagnosis means detecting a cancer that would have gone unnoticed for the patient's whole lifetime. And in fact, if you then treat that overdiagnosed tumor, they label that overtreatment. All right, so if we look at breast cancer in particular, there are certain patients who may be particularly at risk. For example, a patient who's already had previous breast cancer is at risk for another. A patient who's got family history of breast, ovarian, tubal, or peritoneal cancer is at risk. And that's independent of whether we picked up a genetic lesion in particular or not. So some patients have this family history. You run a few genetic tests, including BRCA, maybe TP53, you find nothing. And it doesn't mean that your patient doesn't have a predisposition. It just means that there isn't a locus that we're finding, okay? So some of them may be polygenic. So rather than one gene causing their predisposition, it's more than one. Ancestry is important. So we know that in clients of Ashkenazi Jewish origin, there's a higher rate of BRCA1 and 2. The patients who may already come into the consultation saying, my mom is actually a BRCA carrier, or I was tested at age of this and that, and I've been found to be a BRCA1, BRCA2 carrier. So those are patients that you definitely want to get into a screening program. If a patient had a previous breast biopsy that indicated a high-risk lesion, such as an atypical hyperplasia, you would definitely consider the patient for increased interval screening. And then other risk factors such as age of menarche, age at first live birth, the number of pregnancies, as well as the menopausal status of the patient may inform their risk. If they've had previous radiation to the chest, especially in the sort of adolescent ages, they'd be at risk. So we see that quite a bit with Hodgkin lymphoma, for example, where patients may have had an axillary primary and then had radiation, had this long treatment-free interval, but then later present with breast disease. So just some common mutations, BRCA1 and 2, P10 is another one in a syndrome called Cowden. And then as we discussed, TP53 in the syndrome called Li-Fraumeni. In terms of BRCA1, there's about a 60% absolute risk of developing breast cancer by the time the patient is 70 years of age. And I mean, it's not very common. So only about 5 to 10% of breast cancer patients actually will have, in particular in BRCA1 and 2. There are some online calculators that are found where you could input the detail and it'll tell you this is the patient's chance of having a BRCA mutation. And then you can maybe send those patients for genetic tests. But I mean, certainly in our unit, if you've got a young client with breast cancer or with a significant family history or bilateral breast cancer or breast disease at onset, male breast cancer, those are patients that you would actually refer even if you didn't use your online calculator. All right, and then what about the patient who does not seem to identify a family member who's been afflicted by breast cancer? There's about a 12.4% lifetime risk of all women of having breast cancer. And age is probably the most important consideration when asking the question, you know, should I screen this patient? So we think for clients less than 40 years of age, you should not routinely offer screening because their baseline risk is low. Of course, this excludes patients with familial predisposition. For clients between 40 and 49, the risk is still quite low. However, you know, depending on where your patient is and if they're asking you for screening, you may well offer this patient. So we consider that to be a shared decision-making where the physician and the patient can discuss whether or not this patient should go for screening. Of note is that if you send a young patient for screening, you may detect very dense breasts, which may have a poor yield on mammography. So you may actually miss some lesions that are there, or you may overcall lesions because they may have quite dense breasts. Clients who are at least 50 years of age, those should then start their screening. And it gives us the option to do 1 to 2 yearly mammography. And again, it's probably a risk profile or more of your patient's mindset, whether you want to do yearly versus 2 yearly. And then when do you stop? Because especially if you're doing yearly, that's a lot of mammograms. And the answer is, we think around the age of 74. I've put a star on it because it's quite controversial. It really depends on what you think your life expectancy is in that patient particularly. So things like comorbidities will come into question. There is a systematic review of some of the work I looked at where, you know, because you have to ask the question, how much benefit will my patient derive from going into a screening program? And they give a relative risk reduction of 0.86, which if you look does not cross, the confidence interval doesn't cross 1, which means that this patient does derive a benefit. All right, so what tools can we use? So I put clinical breast exam there because it's there, right? But it's probably not a good tool for screening. However, it is good when your patient has complaints. So if your patient says, doc, I've got a shooting pain in the breast, I've got this redness that's occurring in the breast, then a clinical breast exam is an ideal tool. It has to be done extensively. So you've got to start in the supraclavicular fossa and work your way into the inframammary crease. And you have to examine the axilla all the way down up to the sternum in terms of your axes. There's some units, especially in the UK, where they've got nurses who've been trained to do clinical breast exam, and they've got some nice results there that seem to supplement mammography. And as I said, it's not useful to use as the only tool. However, you can add it to mammography in centers that have been trained on how to do it. And as we said, if the patient's got complaints, then it's a useful tool. Self-breast exam. So here the aim isn't for the client to be able to detect the lesion per se. Its aim is actually for the patient to have awareness. So we want the client to be able to say, what does my breast feel like on a normal day? That way she can say, you know what, something is now different. And I mean, in the clinic, I've had one lady who her main complaint was her nipple being inverted. And, you know, many people may have missed it, but she knew. She said, doc, my nipple doesn't look like how it used to. She didn't feel the lump, it was there, but she couldn't feel it. And I mean, you know, she's a patient, so you can't expect that they'll pick up, especially smaller lumps. But for her to be aware of what her breasts feel like. Now, of course, if you're premenopausal, your breasts may change with your menstrual cycle. So that could also introduce some anxiety where patients say, you know, doc, my breasts are dense, you know, should I be worried? But certainly for the postmenopausal woman, we expect that the density of a breast should remain fairly constant, especially over the years. And then the key tool is mammography, and there's different forms, including 2D, 3D, as well as plain film. And it's the tool of choice, certainly, for screening older postmenopausal patients with no breast complaints. And then, of course, ultrasound. Ultrasound is probably more useful as an adjunct to mammography, and again, especially in younger patients. And it's also useful once you detect a lesion on mammography to then go and define it and to guide a biopsy. And then MRI of the breast is an adjunct in high-risk patients, such as the familial patients, especially when you can't delineate lesions on mammography or ultrasound, then you would introduce MRI breast. You wouldn't do it as frequently, for example, as you do mammography. And I've just put in there an entity called gadolinium deposition disease, which is an entity described in some of the patients who've been undergoing MRI surveillance or MRI screening. And it's got cutaneous manifestations, kidney, etc. All right, there's no routine screening in males recommended. And I mean, that's just from a guidelines point of view. But again, if you've got a male patient who'd had breast cancer, that patient would go into some sort of surveillance. If you've got BRCA carrying males with gynecomastia or who've been found to have increased breast density on previous studies, those patients would go into annual mammography programs. Females who've had breast augmentation, it's important that they may not benefit greatly from a standard mammogram alone. They may need the addition of ultrasound and plus minus MRI. And I think that's the case with the old lady I presented with the ruptured abscess. She was screened for quite a while, but nothing was detected until late. And then just to touch on the hereditary breast and ovarian cancer syndromes, where the best described entity is BRCA. These are usually younger patients at onset. We say you must have an index of suspicion for patients whose families were diagnosed. You want to look at 10 years before the diagnosis of that index case. So if, for example, a client's mother was diagnosed at the age of 50, then from the age of 40, you would start screening that client. If there's a significant family history of breast and ovary cancer, again, even if it's in the absence of a found genetic lesion, you would consider these patients to be high risk. Other entities that are associated with the syndrome is prostate, endometrial, and pancreatic tumors. And as we said, you may have male breast cancer patients in this entity, as well as patients presenting with bilateral breast cancer. Just in terms of a biologic, how these patients differ from others is that they will respond to a class of drugs called PARP inhibitors, which we can use in the metastatic setting for breast cancer. And then they're also sensitive to platinum coordination compounds. And in the adjuvant setting in terms of triple negative. Absolutely. And then we may offer prophylactic surgery to these women. This is a contentious issue, and these patients need psychological support as well as counseling. You would only offer once the patient considers herself to have completed her family, and that's because it'll be radical. So you'll have a bilateral mastectomy. You'd have to remove the entire womb, as well as a bilateral salping oophorectomy. And then just a word on modifiable risk factors. So a lot of the patients will not have the genetics as we discussed. So then the rest is, again, if you're seeing a patient in MOPD or in renal clinic, is to try and address some modifiable risk factors, including smoking, alcohol cessation, a healthy diet, an active lifestyle. We know that insulin resistance is positively associated with an increased risk of breast cancer. Breastfeeding decreases your risk, but I don't know if that'll be a meaningful discussion with a 55-year-old in the hypertension clinic. And then the role of hormone replacement. So patients with an intact uterus, we know that if they get opposed estrogen, so if they get estrogen with progesterone, that may increase the risk of breast cancer. Whereas in the patient with no uterus, and if you use then unopposed estrogen, so estrogen monotherapy, we think that in those patients, their risk of breast cancer may be at least equal to the population or even decreased. Combined all contraceptives, the risk that they have in terms of breast cancer, we think it's transient, which means if the patient stops the contraceptive after 2 years of stopping, their risk normalizes to that of the baseline population. And then just to move on to prostate cancer. So this is the pie chart and how it looks for male patients. So if you look, that orange part of the pie chart is prostate cancer. You can see it almost looks like how breast looked on the other side. And then you see colorectal trailing closely behind, and then lung cancer. And then again, this entity called carcinoma of unknown primary. Prostate cancer remains the highest prevalent cancer in males if you exclude squamous as well as basal cell carcinomas of the skin. It's the 5th leading cause of cancer deaths globally. And then in the South African context, we tend to see more aggressive disease in Black patients, and it tends to be more advanced at onset, where you study them and you find things like bone metastases at presentation. Just to say that there's quite a number of male patients who will happily walk around with this disease without knowing it, without having symptoms, and will probably die from other problems, not from prostate cancer. So then with that said, who should you screen? So the opening statement says these must be informed asymptomatic men with a life expectancy of at least 10 years. You'll see 10 years recurring across all of these topics. Do not offer screening to patients who are unwilling to go treatment. And I mean, you have to be able to imagine if you're offering, for example, radical prostatectomy to these patients, it's not without side effects. So some of these clients will lose their sexual function, they may lose continence, they may have other problems introduced by radical pelvic surgery. Do not offer screening to clients who are above the age of 70. So again, it's got a star because it's controversial. And I recently gave an awareness lecture to a church, and the men there were universally above 70. They were all in the 80s, and they came to me and they said, "Hi, doc, but what do you mean? You know, should we not?" And I said, "Look, I mean, I'm presenting to you what's found. If you want to have your test and you're willing and you think you're fit, so as a physician, you'd have to say, you know, if this is a marathon running 8-year-old, who you think his individual life expectancy may be longer than 10 years, absolutely offer that patient screening." You know, to say what's the life expectancy of the patient may be very difficult, but you'd have to look at the physiologic age. So sometimes the client in front of you is 8 years old, but maybe looks a bit younger, or maybe looks a bit older. So if you said, well, who in terms of the general public should be screened, the number is from the age of 50. That number drops in Black patients because of what we've just discussed to age of 45. And then I think I'll present just now who counts as high risk, but in these high risk individuals, the number drops to the age of 40. In patients who have had family history of prostate cancer, family history of breast cancer, or who are known to carry BRCA1 or 2, as well as other associated, what we call BRCA-ness. Those are those genes there. Those patients would have to be screened at the age of 40 and surveyed quite closely. And what tool should we be using? So it remains a PSA. It's the test of choice. It does lack specificity, which means it can be raised in entities other than prostate cancer. I mean, typically in prostatitis, in BPH, which travels very closely with prostate cancer. If patient has been instrumented, for example, if they came into the ED with urinary retention and we put in a urine catheter and then doctor takes a PSA test afterwards, that could be falsely elevated. And then things like ejaculation and bicycle riding and the doctor doing, for example, a DRE, those can also transiently raise the PSA. The key there is to then repeat in 6 to 8 weeks, especially if you're not particularly worried. If you are worried, then that's no longer screening, then that's just you doing the diagnostic tests. And I've just listed those cutoffs there. They're not specifically defined. So for example, that first reading says a PSA of 4 is abnormal. So the cutoff is actually age dependent. So if you look, there's there's a table that tells you, if the patient's above 80, this is a cutoff, but they range around the number 4. If it's above 10, you start being suspicious for a cancer. And if it's above 100, it's worrisome for an advanced cancer. So those patients may have things like metastases at diagnosis. All right, the DRE, the digital rectal exam, has been removed from the latest guidelines as published in the CMJAH. And the reason is because there's a poor pickup rate. So for example, very small tumors will not be picked up on DRE. And then the other one is it depends on who's using it. For example, if you've got an untrained doctor or someone who's just starting their practice, they may overcall some lesions on digital rectal exam. And then of course, patient comfort and preference. So it's much easier to draw a blood test than to convince a male patient to do a DRE. It's still important in evaluating symptomatic patients. So if the patient had urinary complaints, for example, you definitely want to do a DRE. Once your PSA comes back and it's positive, you would definitely proceed to do a DRE. And then in countries where they may not have access to a PSA, for example, you would still use a DRE as a tool. I won't go through this, but pretty much if you've done the PSA test in your client in MOPD and you're worried what to do with the result, there is this table and you can put it up on the CMJAH in May 2020. And then cancer of the cervix. So it is an important, it's the second cause of cancer morbidity in South Africa. Even after the advances in the HIV space, it still remains an important tumor with a mortality rate that's still quite high. And if you look, the prevalence in South Africa is about 22 to 27 per 100,000 women, whereas the global average is 15. So we're not doing well in that space. Having HIV on its own confers a woman 6 times a risk of a pre-malignant as well as invasive cervical cancer. And then the co-prevalence with HPV increases that risk exponentially. So the WHO had a meeting in May 2018, and they strategized that they'd like 90% of girls vaccinated with the HPV vaccine by the age of 15, and that women who women should undergo screening with a good tool. So you do have to look at which tool we're using, and by the age of 35, and they would have to do it again at the age of 45. For patients whose studies come back positive, whether it's pre-malignant or invasive disease, they would like at least 90% of them to achieve cure. So which tools do we use in this setting? So 99% of all cancer of the cervix is due to HPV. There are different serotypes, which I'll show just now, but 64% of them are due to 16 and 18. Those are the genotypes. We do HPV partial genotyping in South Africa, and we think it's a much better tool. So the genotyping includes a liquid-based collection where it's quite similar to a pap smear. You get your endocervical fluid, but instead of sending it for a cytologist to review, you can run a PCR-based test on the liquid. Therefore, it doesn't lend itself to all the errors that can come with a standard pap smear. The problem with cytology is, of course, it can be labor intensive, so you need a cytologist, and then it's got a long turnaround. So if you look, I've got a few ladies that we've sent for pap smears, and they'll wait for about 3 months or so before getting their result. And then some of the normal cytology may actually still have high-risk HPV within the sample, which may miss out on an opportunity to treat. Oh, just by the way, the liquid-based collection in other centers, the lady can actually collect her fluid herself and bring it into the hospital, a bit like a sputum. All right, so the current recommendations on who to screen for cancer of the cervix it breaks them down into low risk and high risk, with low risk really just being HIV negative patients. For those patients, if they do wish to undergo screening, you can screen them at the age of 25. That's per local guidelines, but the age of 30 may be the better one because it reduces false positives as well as overtreatment. And then you would do it 5 to 10 yearly if it was negative. And after 3 previous negative results, you can stop screening the client at the age of 50. But if there's any abnormal prior result, including dysplasia, etc., you can extend the screening to the age of 60. In high-risk patients, so high risk is really just HIV positive patients, as well as patients who have been typed positive for HPV through a previous study. Those patients would screen much earlier, so at the age of 25. But the other one is when you diagnose HIV, for example, at that time you should be sending a patient for screening. So I won't go through this table. So again, it's in the African Journal of Obstetrics and Gynecology, published last year, and it tells you kind of what to do with your screen result should it be positive. So just a word on primary prevention. So again, primary prevention means you're removing risk factors for the disease so that the disease doesn't occur in the first place. So around 7 in every 10 people will actually have HPV at some point in their lifetime. And in particular, 16 and 18 are high-risk genotypes that can cause not only CA cervix, but things like anal, penile, and even oropharyngeal. The target population is 9 years, which the government has worked out to be about grade 5. And it's a school-based vaccine program. So instead of them coming to local clinics or to the hospitals, the system goes to the schools to give the vaccine. They get 2 doses. The first one will count as month 0, and then they must get a second dose at month 6 or up to month 12. Parental consent is, of course, necessary because these are 9-year-olds, and it's free in South Africa as long as the parent gives consent. What I read is that in the IEB schools, it may not be rolled out. So I'm understanding that if you in private schools, you may have to pay at a personal cost. We have not met our targets. So the EU has about a 77% uptake of the vaccine, where the US has about 85%. I couldn't find our number. However, in 2020, due to the pandemic, people stopped giving consent for their children. So only less than 3% of girls were vaccinated. And these are just some of the vaccines. These are branded vaccines. I'm not sure if generics are out, but the one that's given in our schools is the top one, Cevavarix. Huh? Yeah. And it's a bivalent vaccine, which means it contains the 16 and 8 protection against 16 and 18. And then there's Gardasil, which is quadrivalent, and it's got a 9-valent one, Gardasil 9, which offers even more protection. These are all subunit vaccines, and they're produced from a single virion that forms virus-like particles, but it does not have HPV DNA, which is something people were worried about with the mRNA vaccines from COVID. And as we discussed, HPV is responsible for other tumors, so these clients are also protected, and in addition, they're also protected against genital warts. And then just a quick one on colorectal cancer. As we've shown, it's common in both genders. The rationale to inform screening for colon cancer includes this diagram, which is the adenoma-carcinoma sequence first described by Bert Vogelstein. And in the hypothesis, your patient has some sort of familial predisposition and then gains sequential mutations. And each mutation confers the lesion more and more sort of invasive and metastatic potential. Oh, so the rationale then is that if you pick it up in the sort of adenomatous phase, you can cut out the adenoma. Or if you've got a lot of polyps, you can remove that part of the gastrointestinal tract that's afflicted and hopefully avoid invasive disease. So who should we screen here? So again, you would like to break your patients down into high risk as well as average risk. If the patient has had previous colorectal cancer, they've got a high risk of another one. If they've had adenomatous polyps, they're at risk. If the patient's got a family history of colon cancer or an advanced polyp in the family, and I've listed what advanced polyp means. In the US, only about 5 to 10% of colorectal cancers are due to a familial predisposition. That means that the majority, about 90% of patients, will not have a familial predisposition. It would be nice to have local data. So if anybody's looking to do their MMed, to say what is our incidence of familial cancer syndromes in colorectal cancer. So Lynch syndrome is a very important topic where there's an autosomal dominant pattern of inheritance with multiple individuals within the family being affected across multiple generations. And it can happen in an index case, so a patient who does not give a history of colorectal cancer in the family, etc. It's highly penetrant. What that means is if you've got the gene, you're quite likely to then develop the disease. It's usually a young age at onset, and I've seen at least one in our clinic who was at the age of 19, quite young female. And you have to fulfill the Amsterdam criteria, which I'll just show now. And the cancers in this entity aren't just colon, they include also small bowel, endometrial cancer, cancers of the ureter, as well as the renal pelvis. So these are the Amsterdam criteria. May not go through them, but effectively, it shows that you have to have a family history of any of the tumors that are describable in Lynch syndrome, and that it would have to be a young age of onset, with at least some of the individuals being younger than 50. So for us to say you've got Lynch syndrome, you'd have to have the Amsterdam criteria, plus to have a germline mutation in one of the DNA mismatch repair genes, which I won't spell out. We offer this in our institution, but as a somatic test on the protein on the tumor sample, but you are able to do germline testing. And then the other entity is FAP, where we've got multiple colorectal adenomatous polyps, typically quite a lot of them, more than 100 polyps found at C-scope. And it's a rare entity where only less than 1% of colorectal cancer, certainly in the US, have this entity. It too has an autosomal dominant pattern of inheritance, and there's a near complete penetrance of colorectal polyps. What that means is if you have the gene, almost 100% chance that you will in fact have colorectal polyps. And in fact, I looked at one paper that said there's a 100% chance of colorectal cancer as well. So the gene involved is the APC gene located on chromosome 5. And then there's an entity that mirrors FAP called MAP, where there's a different gene, that's the MUTYH gene. So in these patients with a familial predisposition, when would you commence screening for colorectal cancer? The answer is at age 40 or 10 years younger than the affected member. So my client who's 19 years old, technically, I must start screening on her first degree relatives at the age of 9. And you would screen every 5 years in these clients. The NCCN suggests that you do your first repeat at 3 years and then go to 5-yearly if negative. C-scope is the most agreed upon screen tool in this entity. You'll see in the average risk patients there's other screening tools. However, in familial patients, you definitely want to do colonoscopy, and the reason is that you can also go and sample any polyps that you find. But remember, for patients with isolated polyposis, you can remove that polyp, which may actually be curative. So these are the average risk clients. What that means is these don't seem to have a familial pattern of inheritance, and they're just by far the most common patient who has just a sporadic tumor. There are some risk factors which I've listed. They're quite controversial, including things like aspirin, and there's quite a bit of data, to be honest, on aspirin, but everybody's got things in there. There's caffeine and vitamin B, and there's a role for things like ADT. They think that patients on androgen deprivation therapy may also have a high risk of colorectal cancer. There's lots of discussions on microbiomes as risk factors for colorectal cancer, but these are some of the more established risk factors, certainly low fiber diet probably being a one that stands out. And the average risk patient, when should you offer that patient screening? At age 45. So if you've seen them in MOPD and the discussion comes up, you can certainly offer them. In the EU, they only start the screening at the age of 50. And then if your initial screening tool is negative, you can then offer them 10-yearly screening. And then again, you exit screening at the age of 75 based on the discussion of life expectancy. Some of the clients, if our registrars are listening in the clinic, we see patients who've had colorectal cancer, went through surgery, completed their adjuvant treatment. These patients must have a first-year surveillance scope at 1 year. And then after that, you scope them at 3 years, and then you do 5-yearly intervals. Other groups recommend that you just screen them 3 yearly after that first scope. So as we said, there are other tools in the average risk patient, and they include stool-based tests, including fecal immunohistochemical testing. They include a multi-target stool DNA testing, as well as a guaiac-based fecal occult blood test. There is another tool called CT colonography, which has been described as a virtual C-scope. And that's just because there are some issues with C-scopes, including labor intensity. You need to have a hospital that's got the right infrastructure, consumables, and you need to prepare your patients properly for a C-scope, as well as patient comfort or discomfort. If, however, you do manage to do C-scopes, the cool thing with them is if it's complete, which means you manage to have a look at your whole colon, then you don't need to worry about doing interval tests in between the 10 years. Oh, and that's me.